Good morning. Thank you for joining us. This is the Alzheimer's Disease and Related Conditions Advisory Committee meeting. Today is Monday. No, it isn't. It's Thursday, February 6th, 2025. We're going to give just a few more minutes for people to log on and get settled, and we will get right into our business. Great, our numbers are going up. Wonderful. All right, I think we are ready to begin this meeting. Again, welcome. This is the Alzheimer's Disease and Related Conditions Advisory Committee. Today is Thursday, February 6th, 2025. We welcome you in a virtual as well as an in-person space here at the California Department of Aging here in Sacramento, 2880 Gateway Oaks Drive. Next slide. I am Carol DeAndres. I am the manager for the MPA stakeholder and public engagement here at the California Department of Aging, and I am happy to be here with you. Next slide, please. Just a few meeting logistics before we get into the content of the meeting. You can join by smartphone, of course, tablet or computer. This is the phone number that you can join, and our meeting ID number is also on the Cal HHS website. Live captioning and American Sign Language interpreting is available. Thank you to Rex and Bailey, our ASL interpreters. Live closed captioning is available to you via your Zoom webinar functions. Down on your ribbon, so on the bottom of my screen, you can click on that and enable them. If you don't see it for some reason, you should have something called More on your Zoom screen, your options, and it should be under there, but closed captioning is available to you. Following this meeting, the slides, transcripts, and recording will be posted to the Cal HHS Alzheimer's Disease and Related Conditions Advisory Committee webpage. So please check that out. Next slide. The chat function is enabled for committee members and Department of Aging staff and other state staff, inviting guests to share meeting-related resources and information. And the public is able to view that content shared in the chat, but the chat is not enabled for the public. We do invite the public to provide comments. You may hold your comments until the designated public comment period, and there are 2 on the agenda. You can send additional public comments here in the Q&A function that is enabled, and we will endeavor to respond. Also, please feel free at any time to send your comments or questions to the Engage email box, which is engage, ENGAGE @aging.ca.gov. Next slide. As I stated, there will be 2 public comment periods. In person, if you're in the room with us today, you can raise your hand and one of our colleagues in the room will call on you. If you are attending virtually, please use your raised hand icon in your reactions feature or press *9 on your phone dial. And that will indicate that you have a comment, and we will unmute your line and you may give your comment. Do know that you have, in order to get to all of our comments, we are limiting public comments to 2 minutes. And of course, at any time, you may submit written comments to our Engage email box at engage, ENGAGE at aging.ca.gov. Next slide. So at this time, I will like to turn it over to our co-chair, Catherine Blakemore, to take us into the meeting. Good morning, Catherine.
Thank you so much. Welcome, everyone. Thank you for attending. It's quite rainy here in Sacramento this morning, so I hope all of you are well with the weather. And I just want to start by thanking all of the staff who put this meeting together. You can see so many of them on the screen, led by our wonderful director, Susan Damaris. So thank you for all that you do to support us. And I want to just acknowledge that we have two new members that will be joining us. One is Dr. Quasi, and we'll get back to you and let you say, well, why don't you just introduce yourself and say something about yourself now? And I think you're representing the Commission on Aging, right?
Sure, yes, thank you. Yeah, my name is Faisal Kazi. I'm in Southern California. I'm a neurologist, so my day-to-day activity does involve Alzheimer's patients. Um, so I've been on the California Commission on Aging. This is my second term, and this is the first time around I think we have designated representation on the Alzheimer's Related Disorders Committee. So happy to be here to learn from all of you and hopefully participate in a meaningful way. Thank you.
Terrific. And our other member that was appointed by the Senate is Senator Aruen, and he is not here, but his staff is intending to join us, although I don't think I see her yet, and that person is Carmen Ayan, or Ayan. And so when they come, we'll maybe ask Carmen to introduce herself. This is again another bylaws change, and we'll be talking about those, a statutory change where both the Assembly and the Senate can have non-voting members, which is a terrific connection for the committee. And now I want to just take time to ask members to introduce yourself and just say something briefly about the position you hold and the any organization you're connected with. And why don't we start with our amazing Vice Chair, Wynn.
Good morning, everyone. Wynn Canio. I'm a geriatrician and a psychiatrist here in the North Bay. I am the mental health representative for this committee. Welcome.
And I know we have Carlos who is in the room. I don't know if the room has sound yet, so maybe someone can let us know, attending in person. Or we'll go back to, it's okay, we can go back to you too. I think they're checking. Why don't we go on to Sally? Introduce yourself and welcome.
Good morning. I'm Sally Bergman. I am an attorney in San Mateo, California. Focus of my practice is older adults. So, of course, I frequently see families with Alzheimer's and related dementias.
Perfect. Welcome. Barbara.
Hi, I'm Barbara McClendon. I'm with Alzheimer's Los Angeles, and I'm representing service providers to people living with dementia and their caregivers.
Perfect. Claire.
Good morning, everybody. I'm Claire Dam, the Chief Mission and Program Strategy Officer with the Alzheimer's Association Northern California, Northern Nevada chapter, and I am also representing community organizations representing people with dementia.
Wonderful. Todd. For some reason, we can't hear you. We cannot hear you yet. So we're going to come back to you. No worries. We'll let you figure out your microphone. Always something with Zoom. Celine.
Good morning. My name is Celine Regalia. I'm Director of Operations at Providence Community Health Napa Valley. We have an Alzheimer Daycare Resource Center, and I'm the Alzheimer Daycare Resource Center representative.
Wonderful. Thank you. Dr. Gallagher Thompson.
Hi, good morning, everyone. Yeah, I'm Dolores Gallagher Thompson, and I'm a geropsychologist and a research professor at Stanford. So I think I represent both academic medical research and also mental health. I think I straddle both of them. So I'm not sure under what designation I'm actually on this committee, but I think I like to contribute to both of those areas. So
That's wonderful. Thank you. Myra, welcome. Yep, you're going to unmute. We'll just wait for you to do that. There should be a little microphone button maybe towards the bottom of your screen that you can click on. It's always hard to find these things. How about you look for it and we'll go to Dr. Mobley and then we'll come right back. Sounds
Hi,
good.
Bill Mobley, UC San Diego, a neurologist and neuroscientist.
We're
Thanks for
great to see you. Thanks for
thank you so much.
joining. Carlos, you want to introduce yourself?
Hi, I'm Carlos Olivas. I am a family caregiver from Sacramento, California.
Okay, we're going to see if Todd figured out his technology.
Can you hear me now?
We can.
There we go. Sorry about that. Good morning, Todd Shutter. I'm with Active Care Living. We own and operate 7 memory care communities in Southern California, and we're also a vendorized provider to the regional center for folks with intellectual and developmental disabilities and dementia.
Wonderful. Thank you. I think Myra's still working on her microphone, and I want to just make sure we get to everyone else. It's all right. We're going to come back to you. Myra Garcia is one of our individuals with lived experience who just contributes greatly to every meeting. So we're really happy to have you with us. And I don't know if Carmen, I just saw Carmen pop on briefly, but now it looks like she has a photo. So Carmen, are you there? Welcome. We're so glad to have you. And do you want to just briefly introduce yourself?
Yes, good morning, everyone. Carmen Aon with Senator Eric Gein's office, part of his legislative team, and very nice to meet you all.
Yeah, we're grateful to have you and excited to have a legislative presence. Did I miss anyone else?
I'll go, Catherine.
Oh, thank you. Thanks so much, Julie.
No problem.
Didn't
Hi,
see.
Julie Soulier with California Health and Human Services Agency, and I help support CDPH.
Wonderful. And I am Catherine Blakemore, and I have the privilege of being the chair for the commission, and I am a family member representative. Jason, did you have your hand up? Thank you.
Hi, I'm an alternate. Sarah Farias is usually in the spot representing the California Alzheimer's Disease Centers, so I'm filling in for her today.
We're so happy to have you. I think you were here maybe at the last meeting or the meeting before. Okay, I am going to stop with introductions because we have our new Health and Human Services Secretary with us, and we want to give her time to be able to introduce herself. And so, Kim Johnson, I saw you a minute ago.
I am here. Good morning.
Terrific. Good morning.
Thank you, Catherine. And thank you all for what you do, first and foremost. Just tremendous expertise from so many different perspectives on this group. I am grateful for the opportunity to join you today and listen and learn from you as valued advisors. You are part of a proud tradition of stakeholder engagement at the California Health and Human Services. And in fact, you may be our longest standing advisory body dating back to 1988. We can point to countless positive policies and budget actions linked directly to this advisory council. So you are not only providing that advice, but it's being embedded and activated into the work that we do. This committee has also served as a powerful example of how important it is to include the voice of those personally impacted by Alzheimer's and related conditions as full members of the committee. These personal perspectives and lived experience keep us laser focused on real-time, real-life issues. So my sincere thanks to the consumer members Myra Garcia and Kim Graffio and for your service. Thank you. When ensuing office in 2019, Governor Newsom made it a priority to address the needs of those impacted by Alzheimer's and their families through the establishment of the Governor's Task Force on Alzheimer's Prevention and Preparedness. We're fortunate today to have Dr. Canillo chairing this group as an original member of the Governor's Task Force. This body adopted 10 key priorities, and I'm so proud to say that all 10 of these priorities have been advanced through the Master Plan on Aging. This is due in great part to your focused, effective advocacy and leadership. Since its inception, this committee has challenged the agency to break down silos and work more effectively and efficiently across departments, excuse me, for the benefit of people living with dementia and their families. Today, we have a guide that reinforces this whole of government, whole of society approach that you have long advocated for, our state's Master Plan for Aging. This committee is absolutely vital to the Master Plan for Aging's success. I was pleased to see that you identified critical priorities in your recommendations elevated at the Master Plan on Aging Day of Action. In particular, long-term services and supports, financing and affordability, access to dementia-capable adult day services, as well as leveraging community health workers to expand access to dementia-capable service coordination. Your priorities reflect the importance of a robust long-term services and support system that uplifts navigation, access, workforce, and financing. These are the 4 pillars of a person-centered system of care as reflected in the Master Plan on Aging initiatives released just last week at our Impact Committee, and I was glad to attend and participate in that. I'll close by encouraging you to amplify your advocacy in the face of uncertainty, using your voice. We always appreciate it. One thing we know for certain is there are more older adults now and for the foreseeable future. And the fact remains that age is the greatest risk factor for Alzheimer's and related conditions. So please continue sounding the alarm for all to hear, ensure that we are intentionally focused on these issues. I was pleased to see your agenda today focusing on Proposition 1 and behavioral health transformation. My understanding is this advisory committee has been instrumental in elevating the needs of older adults and family caregivers in this space, and I urge you to continue vocalizing the community's needs, just as you have done so effectively with Down syndrome, law enforcement training, CalAIM, and disaster planning and emergency response in recent years. While we confront significant challenges today as a state, I am always heartened to see the tremendous partnership and leadership of community. Thank you for sharing your passion, your expertise, and your lived experience with us to inform our shared work. I will just tell you that is how I like to go about doing business, is engaging with community, using data and evidence and pairing those together with life experience to really help ensure we are meeting the needs of all individuals and especially this population. So thank you for your work. Thank you for your advice, and we look forward to continuing our progress together. Thanks so much.
Thank you so much. I've had the pleasure of working with Secretary Johnson on a few things lately, and I will say she is a person with a vision of how can California work for everyone. She has the heart of an advocate and deep community connections, and honestly, the experience to get things done, which is what I think we're going to need in this next bit of time with some creative problem solving. So just grateful to welcome to you. And if you have a moment, we have at least one and maybe a couple of questions. So thanks so much, Barbara.
Hi, thank you, Catherine. Welcome, Secretary Johnson. It's just a pleasure to have you with us today. I wanted to just take a moment to address an issue that's kind of personal for me. I live in the Pasadena area, and so we have been really affected by the fires. And in particular, I just wanted to draw your attention to the Altadena community, which was just up the road from me. And, it's a community that has many multi-generational families. And so if you've seen any of the news coverage of it, you've probably seen 3 generations, with a mom who might be 95 years old, who lost all of their homes. So, I'm hoping you'll be a champion for older adults when the state is looking at that $2.5 billion in funding that has been, it's so urgently needed, and we are so appreciative of it. But I've seen it. I've heard the stories of older adults who are flat out overwhelmed by what the next steps are. And so these are just folks who are going to be really challenged to be able to figure out how to navigate this. And so I hope that, there'll be some special consideration and oversight and support for these individuals and their families as they put their lives back together. Thanks.
Thank you, Barbara. And my heart, first and foremost, with all of those impacted. So please know that we are in real time responding to exactly what you just identified. I spent about half of January in Pasadena and Altadena area. So I got to experience firsthand engagement with survivors, looking at the disaster recovery centers and all of the other shelters, and actually also visited the senior center, because obviously, tragically, the Altadena Senior Center was destroyed in this event. So I just want you to know that being on the ground is so valuable. I know Director Morris from the Department of Aging has also been there. Really just seeing it firsthand and experience, it gives a different level of recognition and understanding to all of your points of then how we are working together on ensuring that those who might need additional support and getting those connections to resources are happening in real time. So what are the different modalities in addition to a place where people have to go, in addition to online? How are we actually being very intentional about people who can maybe not do either of those things, and are maybe connecting with other and new resources that they haven't navigated before? So I really appreciate you raising this, and know that we are absolutely with you and noting that where there might be gaps in addressing the needs, particularly of older adults and those with dementia. We are here to do that. So thank you for uplifting that, and we are committed to doing so.
Thank you. Appreciate that.
Any other questions for Secretary Johnson? Okay, we know you are busy. We appreciate your commitment to aging and people that were affected by the fires. So thanks again for joining us. And you can be assured we'll have another great set of recommendations at the end of this meeting too.
Looking forward to it. Thank you so much, Kevin.
Thank you. Thank you. Myra, do you want to just take a second and introduce yourself? That tech challenges have been solved.
Yes, I'm sorry that it took so
No.
long. But Myra Garcia, living with the disease.
Thank you so
And
much.
I live in Upland, California.
Terrific. Thanks for that. And glad you are here and able to fully contribute. We always look forward to that. I wanted to make sure we got to Secretary Johnson on time because she is very busy, which means we didn't yet approve our minutes. And so you have the minutes from the November meeting in the link on your packet, and they're also posted. But I would entertain, first of all, does anybody have any comments or questions about the minutes? Okay, I would entertain a motion to approve the minutes.
I would make a motion to approve.
Thank you, Sally, for that. Is there a second?
Second.
That was Dr. Mobley? Is that?
Todd.
Oh, Todd, thank you. It's hard to see whose screen lights up so quickly. I feel like it's an eye test. All right. Any further discussion? All in favor, say aye.
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 Thank you. Any opposition? Any abstentions? Okay, the minutes are approved. So I think we have successfully completed our the business part of the meeting, and we get to go on to our next portion, which is elevating persons living with dementia and caregivers, and the Proposition 1 behavioral health transformation. And I am going to turn it over to the amazing Wynn Canio, and who is going to lead us through that session with a really terrific group of presenters. So thank you.
Thank you so much, Catherine, for starting us off. So in the next hour, we will be sharing some significant updates on our behavioral health transformation. As both a geriatrician and a psychiatrist, I frequently treat patients with dementia in Marin and Sonoma counties, generally diagnosing typical types of dementia and medically addressing the underlying conditions is relatively straightforward compared to the other common recommendations, such as creating a supportive environment, managing behavioral symptoms, and providing support for caregivers. I would like to briefly share the story of Dawn to illustrate this point. And I actually saw Dawn today for a follow-up, but approximately 1 year ago, I consulted with Dawn, who is 81 years old and a retired restaurant owner and importer. His brother Bob sought a second opinion regarding Dawn's dementia diagnosis and the management of his psychotic symptoms affecting his care. He saw a neurologist outside of our health system. At that time, Dawn reported experiencing some memory loss, which he believed to be common among individuals of his age. While he acknowledged he occasionally lost the train of thought during conversations, he denied any other symptoms such as misplacing items or getting lost. Dawn had been residing in a homeless shelter until 4 months prior when his brother found him. He recounted an incident from about 1.5 years ago where he was assaulted by a group of young individuals, resulting in 4 fractured ribs. More recently, he was robbed by a woman who took his wallet containing cash, debit cards, and food stamps. And before living on the streets, Dawn had been staying actually in a house owned by his son, but was asked to move out when his son got married. He expressed sadness by the lack of contact with his 4 adult children. So his brother Bob shared that he and Dawn had not spoken in 20 years. He would call him, but Dawn would neither answer nor return his calls. Recently, he received a call from Dawn's daughter, who lived in Canada, asking for help. She mentioned that Dawn was living in his car after her brother had asked him to leave the house 3 years prior, until a few months ago when his car was set on fire. He ended up in the hospital following an assault, and Bob managed to convince him to live closer to him. Living with his family was not an option, so he arranged for an apartment for him. Bob reported that Dawn would get disoriented and could not figure out how to use the smartphone he gave him. He also had more difficulty expressing himself. Dawn exhibited paranoia, believing someone was knocking on his windows and entering his apartment. He sometimes suspected his wife of trying to poison him when given food and claimed that the television was talking to him. Bob wished to help his brother more, but was experiencing increasing arguments with his wife over the time and financial resources supporting Dawn the last 4 months. These accusations also affected her emotional well-being. So after the evaluation, I diagnosed Dawn with a major vascular neurocognitive disorder, formerly known as vascular dementia with psychotic symptoms. I prescribed medication to treat his symptoms. Our team also provided Bob and his wife with education and resources and connected him with Family Caregiver Alliance and Alzheimer's Association for additional support. Last week, I spoke with Bob and his wife, who reported that Dawn has been doing better and no longer exhibited psychotic symptoms. However, they expressed concern about their ability to continue financially supporting him if he requires more care in the future. Like I said, I saw Bob this morning, and he indeed is doing well. But we're worried about how to support them in the future. So this highlights the necessity for a comprehensive care plan that addresses both the medical aspects of dementia and the emotional and practical challenges faced by patients and their caregivers. Although addressing these issues is challenging, given the limited availability of behavioral health professionals and services, our behavioral health transformation aims to improve access to these essential services within our state. So that's the end of my introduction, and we have a lot of amazing folks that will talk about this behavioral health transformation and proposition. Susan will be our next presenter for the Master Plan for Aging. She will discuss the integration of dementia care within the broader Master Plan for Aging and highlight recent developments and future goals. And I will introduce the other speakers afterwards. So thank you, Susan.
Thank you, Dr. Canio. Thank you so much. And thank you for focusing on this important and timely topic today. I really just wanted to frame a broader context. There are a lot of similarities between Alzheimer's and dementia and behavioral health in terms of how we approach the two topics that are so closely related and there's strong intersection between the two. So as a frame of reference, I wanted to just refresh the group on California's Master Plan for Aging and the 5 bold goals, because older adult behavioral health sits within all 5 bold goals, as does Alzheimer's and dementia. And the example that you just shared, thank you for that, really illustrates Goal 1 of the Master Plan for Aging is housing for all ages and stages. So thank you for that very, just this morning's example with one of your patients who was precariously housed. A big focus of the state's Proposition 1 and behavioral health transformation is to secure housing for people with behavioral health conditions. So we don't want to lose sight of that in our conversations about behavioral health. Goal 2 of the Master Plan for Aging is Health Reimagined. And traditionally, this is where older adult behavioral health has lived in terms of the clinical work in physician offices, outpatient clinics, hospitals, and institutions. And part of reimagining health for older adults is how can we bring more behavioral health supports to the home and the community and meet people where they are and where they live, especially on the prevention and population health sides, to intervene earlier in places where older adults are most comfortable and they have trusted community partners. Goal 3 of the Master Plan for Aging is inclusion and equity, not isolation. And under this goal is really where we've been focused from the outset of the Master Plan for Aging in addressing older adult isolation and loneliness. And that is a big focus of our behavioral health work. And huge body of evidence, journal articles, continuing research that's being done in this area, and of great concern in California statewide today. We have about 1 in 5 older adults who live alone. And we know that people can live alone and be socially engaged. And we know that people can live in a household with others and be isolated. But this is a trend that we're closely following that, is definitely on the rise. And in some counties in our state, it's bumping up closer to 30% of older adults who live alone. And that does make a situation ripe for isolation. Goal 4 of the Master Plan for Aging is caregiving that works. Under this goal, it's twofold. 1, the paid professional staff, in particular the direct care staff. This would be in-home caregivers, in-home supportive services, as well as the staff, social workers, psychologists, nurses, who may not have specialized training in geriatrics, gerontology, or Alzheimer's and dementia. So really focusing on that paid workforce and making sure that they have the skills and training they need to support the very unique needs of older adults with behavioral health needs, older adults and family caregivers supporting a loved one with Alzheimer's or dementia. The second part of the caregiving that works is, of course, the unpaid family caregiver, family and friend caregivers who need tremendous emotional and psychological support to fulfill their role. And evidence, the Department of Public Health, the Caregiver Burden Survey that we conduct as a state with the Behavioral Risk Factor Surveillance Survey and others point to our benchmarks through the Master Plan for Aging, which you can follow on the Aging Data Dashboard, really point to caregiver strain and caregiver burden. And then the last goal of the master plan for aging that again ties directly to Alzheimer's and dementia as well as behavioral health is goal 5, affording aging. Under this goal, we recognize that so many individuals and families cannot access the home and community-based services and the long-term services and supports that they need to live independently and to thrive at home and in the community. And under this goal area, we are looking at affordable and accessible behavioral health supports that can help individuals with behavioral health issues, mental health conditions, substance use disorders, as well as can support family caregivers. And part of the strain on individuals and families in the behavioral health space is not knowing what is paid for, how much it's paid for, and how to access the services, the behavioral health supports that they need, especially if they do not have the financial resources to pay out of pocket, which is why we're very interested in some of the home and community-based interventions that are lower cost and more easily accessible and affordable for older adults in our behavioral health conversation. So you will see in the Master Plan for Aging, the new initiatives that were just released last week that Secretary Johnson referenced. We will share those in the chat with you. There are a handful that focus directly on older adult behavioral health, but that is not to say it's limited to those initiatives. This entire Master Plan for Aging frame, these 5 bold goals, securing stable housing is a behavioral health intervention. Building out home and community-based services is a behavioral health intervention. Combating loneliness and isolation is a behavioral health intervention. Supporting and uplifting and training paid and unpaid caregivers is a behavioral health intervention. And last, making all of these services and supports more affordable is absolutely a behavioral health intervention. So we'll share in the chat the recent documents, and I just want you to know as the conversation ensues that all of what we're discussing is in the context and the frame of California's Master Plan for Aging. Back to you, Dr. Canio.
Thank you so much, Susan, for sharing and leading this work. And now I'd like to introduce Emily Harrison. Thank you so much, Emily, for spending some time with us this morning. Emily is a sole caregiver for her mother with Alzheimer's. She works full-time in finance at nonprofit and is taking classes toward her BA, both remotely. So she has the flexibility to meet her mother's needs. She's been a member of an Alzheimer's LA support group for the past 3 years and is grateful for their support during this unique experience. So this morning, she will share her personal experience and challenges facing as a caregiver. But thank you so much, Emily.
Thank you. Thank you for the invitation here. This has been an incredibly hopeful meeting for me personally today, to just hear how many people are working on these issues that are so impactful in my life personally. To give a little background, I am an only child flying solo in this caregiving journey. I'm not quite the sandwich generation. I am married and taking care of a parent, but I don't have kids, so not quite the sandwich generation. I know the focus here is on behavioral health, and so I kind of wanted to give a little bit of history on the journey that I've taken to try and get my mom help post-diagnosis. She actually, for the both of us, have a long history of mental health struggles. She's unfortunately experienced a lot of childhood trauma that has, carried through adulthood and into her journey with dementia. Getting her anxiety treated has been difficult. There is a real fear when going and asking for help that I'm giving the impression of drug seeking, which I found myself silenced and trying to ask for assistance. Even when we were trying to get her diagnosed before she was officially diagnosed with Alzheimer's. You know, the first neurologist I took her to just suggested she lose weight. And the second neurologist that I took her to suggested that she was lazy. She was just trying to get disability so she didn't have to work anymore. And so getting pushback for seeking help with her behavior was also difficult to face, as I also am a person who struggles with mental illness. So advocating for myself is difficult. Advocating on her behalf as well is challenging. When I asked for help, because I have said so many times that I have the gold star, I have the platinum experience of caregiving. I could not be luckier. I could not have a kinder, sweeter, more cooperative person to be taken care of. I'm incredibly lucky in that regard. But I still see suffering. I still see struggling. I can see the absolute panic that she's experiencing. And before she moved in, there was fear about how I was going to handle her mental health and my mental health tangling every single day with no intermediaries. But the challenges have changed as her progression, as she's progressed with Alzheimer's. And there's been a lot of fear that we've been trying to address. And one of the first suggestions was talk therapy. And I wanted to scream at the doctor, which I did not, but I wanted to scream that she's scared because she keeps looking down the hall thinking that's going to be her childhood bedroom. And she's looking for her mom. And she's scared because she's confused all the time. And these talk therapy is not going to help change her brain, but we tried anyway. And then the therapist said she's not a candidate for this. And it was back to the drawing board. And again, just really scared to advocate for her and feeling like a drug seeker. When really what I'm just trying to do is make sure that I can provide the best quality of care for my mom as possible. And in terms of the quality of care that I can provide, I feel is quite limited because of my own mental health struggles. I reached out to Barbara the other day, who has been my point of contact for this meeting, and I was laughing a little about the universe and its jokes because I wondered, should I still speak today? Is this still appropriate? Because this week I've been struggling with my own mental health crisis, and if I was not the only caregiver, if I was not the only person taking care of my mother with dementia, I would voluntarily be inpatient right now. But that's not an option. So I'm home. I've taken a little time off work and I'm trying to care for myself and my mother and keep us both safe. And it's challenging. It's quite challenging. But if there was going to be a crisis right before speaking about caregiving and mental health, what a bang up time for that to happen. So yeah, I apologize that I'm not quite I am not quite bringing my A game today, or and I'm probably missing a whole bunch of notes that I had intended to cover. But if there are any questions or comments, I'm open to them. But I just wanted to thank everyone here for the work that you're doing. It is incredibly impactful. It is incredibly important. And just listening and hearing the efforts that are being made fills me with a great degree of hope. So thank you.
Emily, thank you so much for sharing. This is the reason why we're all here.
Thank you.
When it looked like Carlos has his hand raised too.
Carlos, go ahead.
Hi, I'm a family caregiver too, and I struggle with mental health. And I just want to let you know that you're not alone.
Thank you.
And thank you for speaking out, speaking up. raising awareness to this, because it's important that we understand the needs of family caregivers, the challenges that we go through. This is not easy. It's difficult to say in words how I feel, and I resonate with the words that you just spoke. But no one can understand what we go through unless you've been in our shoes. This is a very important topic, and we need to spread more awareness to the family caregiver.
Thank you.
So thank you again.
Carlos, yeah, well said. I've been doing this for a long time. I'm a professional doing this every day. For some of you, you've heard me share my experience before. I was also a caregiver for my grandmother. I would hear a lot of things, what we need to do. Doing it is a lot different. And I'm hoping that we can all share what worked for us. Everybody's different. So all the ideas out there, as Secretary Johnson said, we need creative solutions. And I'm glad we're all here together to make this happen. So thank you all. And now I think I'm supposed to be, hang on a second. So Deputy Director for California Department of Public Health, Julie Nagasako, and Kristen Theodore, Assistant Director for the Department of Public Health, are here to explain the Proposition 1 and its implication for behavioral health. They will discuss the strategies for integrating dementia care into population-based prevention efforts. Much needed. Thank you so much for being here, and go ahead.
Thank you.
Hi, good
Thank you for
morning.
having us. So I just thank you, and just it's really a privilege to be in attendance of this meeting and hear some of the stories. And so what we're going to do is Julie's going to provide an update on what we've been doing in terms of the population-based prevention planning. And we'll go through that and then be able to answer any questions that you may have. So I'm going to turn it over to Julie, and then we'll have a discussion afterwards. Thanks.
Yeah, thank you so much, Christine. Good morning, everyone. I'm Julie Nagasako. I'm the Deputy Director of our Office of Policy and Planning at the California Department of Public Health, and we're helping to facilitate the Behavioral Health Services Act population-based prevention planning. We have a lot of programs at CDPH that work in behavioral health, and so our team is helping to organize this planning process, and we're so grateful for the opportunity to join all of you today. It's been inspiring and encouraging to hear all the work that you're engaged in and to hear from your direct experiences. I'm going to try to share the context of our planning process, and we also really want to make time to hear from all of you because I think your questions and insight will be really valuable in this ongoing planning effort. Next slide. And there's a lot of content in these slides. I'm going to try to cover like highlights, and then we're happy to share them and continue in discussion if folks have more detailed questions. So I just wanted to start off with discussing the Prop 1 Behavioral Health Services Act requirements. So there are some statutory requirements that define these shifts that are a part of behavioral health funding under Prop 1. And so the piece of it that CDPH is responsible for is that there's a new requirement to dedicate 4% of the total fund to what's called population-based prevention in order to look at how we can prevent and reduce risk, increase protective supports before behavioral health harms occur. So that's a real emphasis of this prevention work. Before, there was sort of a blend of prevention and early intervention, which are both important components. And so under this new model, public health will lead a dedicated focus on prevention, and then there will be continuing work in early intervention as well. So that 4% is estimated to be around $120 to $140 million annually. There are part of the requirement is that a significant portion of those funds, 51%, is focused on younger populations, 25 years or younger, to look at sort of early in life, how do we prevent behavioral health harms? And then the rest of the funding is looking at populations of various ages. And we also understand that some of the prevention work for young people is intergenerational or is community focused. So while there's definitely this call out around behavioral health for young people, the intent around BHSA is to look at prevention population wide. And then there are some additional specifics that are outlined, including, population wide can mean statewide, or it can be a specific county or community. We also want to make sure there's a focus on populations that are elevated risk. And then we're looking to reduce stigma as well, we know is a really critical part of prevention, as well as serving populations that are disproportionately impacted by systemic racism or other forms of discrimination. And then there are key outcomes that we're focused on, which are preventing suicide, self-harm, and overdose. Next slide. There are also there are some additional details here that are part of Prop 1 that they can be sort of statewide programs or in a community setting. An important distinction is also that the prevention funds can't be used for diagnostic services or treatment. So other funding, other resource streams address behavioral health treatment, but this funding is for prevention. And then there are also specifics to sort of if it's implemented in a school, what format it's structured in. And then that CDPH is collaborating with our other agencies, including Department of Healthcare Services, the Behavioral Health Services Oversight and Accountability Commission, Department of Aging, our partners at ADRCAC who work on workforce issues in behavioral health as well. So we're trying to collaborate across the state. Next slide. So in terms of what we've just wrapped up a really intensive planning process in 2024. We know that there are so many different activities that impact behavioral health. And in some ways, behavioral health prevention is a relatively new field. So we wanted to make sure we had a strong grounding, both in existing activities, what does the literature and research show, what could we learn from talking to community members and experts? We're trying to host a series of listening sessions to help continue to inform this work. And so we've had a lot of different audiences that have been informing that process. We also reviewed existing plans under MHSA, which was the model for this funding before BHSA, wanted to understand existing work in the community level as well, because there's a lot of lessons and successes to build on there. And then we've been trying to host different engagement activities to gain input and are continuing that process in forums like this today as well. Next slide. And so there's a lot of different factors when we're thinking about decisions and planning for Prop 1. One is that we're really thinking that there's a value in trying to bring shared focus, alignment, and collective impact. What are a couple of key priorities we could align all of our efforts together on at the state and local level? We also want to continue to make sure equity remains a priority focus, build on the previous work, figure out the roles at the state and local level, and make sure in public health, it's also very important to us to always be building on evidence and data so that we can effectively impact disparities. And then our overall goals are trying to address those risk and protective factors that can help us influence these outcomes listed here, including reducing prevalence of mental health and substance use disorder, reducing stigma, focusing efforts on those who have been disproportionately impacted, and then preventing suicide, self-harm, and overdose. Next slide. These are some of the themes which have come out from the engagement sessions that we've been holding with different audiences, and we add to this with each group that we speak with. So definitely just a strong support for making sure we're paying attention to populations that experience high risk. And older adults is one that has come up in many of our conversations. We also recognize older adults are represented in these other populations as well through different aspects of their identity and experience. So that's going to be a really important population of focus. We also want to make sure that in our process, we're doing a good job with transparency and involving community voice, and again, building on existing work. And we've been learning a lot more about the really incredible state initiatives related to working with older adult populations and behavioral health needs. So we want to find ways to bridge that to be effective and build on that work. And then a lot of good feedback about approaches to consider, especially to think about the role of culture in response in behavioral health, and then definitely addressing issues like ableism, and also considering trauma responsive and social emotional learning approaches to help build skills and supports for all the different partners. And I think also, as noted kind of in our discussion previously, making sure we're also looking at the role of adults, educators, caregivers, and the wider community that's a part of behavioral health support and prevention. Next slide. And then want to also call out that very much on our radar when we're thinking about making sure that there's an older adult lens as we think about our behavioral health planning. We have a lot of programs at CDPH that have a focus on older adults, including our Healthy Aging Initiative. We also have an Alzheimer's disease and related dementias program, our Office of Suicide Prevention, our CalFresh program, helping with nutrition security, and our cardiovascular disease prevention program. So those are also teams that we're relying on for input to help inform this strategy in our behavioral health planning. And then in 2024, we did have an opportunity to connect with the Department of Aging team and get some strategy ideas together about opportunities to build on. We held an expert panel meeting in December, and it was really valuable to have a representative from CDA leadership who could speak to older adult behavioral health experiences, so that could be part of our shared discussion. And then we're also actively reviewing all of our current strategies to make sure that we understand potential impacts and roles related to older adults. And then we're very eager to hear your feedback today as well. We know that as we move through Behavioral Health Services Act planning, there's going to be important roles at the state level as well as the local level to make sure that we have clear guidance and alignment with support from the state, and then the opportunity for impact in communities through local activities. Next slide. I want to share a little bit about just how we're thinking about behavioral health and the lens of prevention. So when we talk about behavioral health, we're referring to sort of a very comprehensive sense of emotional, psychological, and social well-being. And when we think about prevention, that includes how can we be proactive to prevent harm before it occurs. We like to think about the term upstream in behavioral health to look at what are the root causes that might be influencing behavioral health outcomes, which can be part of the community context and the opportunities and supports that individuals and communities have access to. We also think about the importance of intervening early in the life course and throughout life, where there may be opportunities for prevention at different life stages. And then we think of the social ecological lens, looking at the roles of different settings. So it can be their individual, community, neighborhood, systems, impacts on our behavioral health experience. And then health equity as a central focus to make sure that everybody has access to those same supports and opportunities. And then taking a trauma-informed approach, because we recognize that healing and development of resilience are also really critical in this work. Next slide. And then another important lens is considering the role of what we sometimes refer to as drivers or social determinants of health. So factors in the wider environment that can be contributing to stressors or limiting opportunities in ways that can negatively impact behavioral health. So we want to be paying attention to issues of socioeconomic disadvantage, experiences of discrimination, anything that is contributing to loneliness and isolation, the differences in access to support between geographic communities, different places and neighborhoods, as well as sort of fragmentation and polarization, which can be contributing to stressors as well, and physical environment. Are there sort of safe, accessible spaces for people to engage in ways that support their behavioral health? Next slide. And then I want to just look a little bit at this. This graphic shows kind of a continuum of prevention and early intervention. And when we're talking about the role of public health, we're looking at the population prevention lens, which can include, and we'll talk a little more about this, universal and selective prevention efforts. So efforts that are aimed at prevention for the population as a whole or for specific groups that are experiencing greater risk. And then you can see at the other end of the arc, there's early intervention, which might mean sort of indicated prevention or case identification and treatment. So those activities under early intervention aren't part of the prevention funding. Those would be addressed under the early intervention funding. But on the prevention side, we'd be looking at what are things that we can do that help with early prevention to reduce the risk of some of those things that we might see on the other side of the spectrum. Next slide. And then when we're thinking about prevention, we do try to take these approaches that combine universal approaches with targeted supports for specific groups. And I'll kind of build on this in the next slide, if we can go to that. So in terms of universal goals, if we can identify some prevention strategies that we know are effective, part of a universal strategy is to make sure those are available to all communities and population groups in California. So a statewide strategy for universal promotion and prevention. And then we want to do focused efforts to address the context of specific groups to obtain that universal goal. There's an example here, which is focused on youth, but we could use the same model and apply it to other age levels as well. So if the goal was to prevent suicide and overdose for a specific population, we'd recognize that certain groups who have experienced structural oppression might require different types of support and intervention, other partners to be involved in order to reach that shared goal. So that would be a part of our strategy. Next slide. And then when we're thinking about all of this, this is sort of our developing model that we have in mind, which is that our goal is to prevent, so that we can see the downstream outcome of overdose and suicide by reducing risk factors and increasing protective factors. So we want to reduce exposures to adversity, to behavioral health harms, to chemical harms, to digital harms, which can all contribute to stress, anxiety, and depression, which can then contribute to those health outcomes that we're trying to prevent. So we want to reduce the risk factors and then increase support for the protective factors to help foster hope and connection and purpose and meaning. Next slide. And we're thinking that part of the approach for doing that would potentially be in these focus areas. And we've been getting feedback on these and revising them. The first one is social connection and belonging. We just know how critical that is for all populations and that there can be a lot of barriers to it. And so we want to see what are things that we can do to improve social connection and belonging. And the other is mental health and well-being awareness and development, helping people to become familiar with mental health conditions, understanding how to communicate about them and what supports might be available. I think that that's important too as part of stigma reduction. And when we think about those two focus areas, we also want to keep in mind what are the upstream and structural supports, those underlying drivers that we might need to address if we're going to be effective. Next slide. So in terms of our planning process, we can talk a little bit about what's coming up. We can go to the next slide. So for 25-26, the main thing we're doing this year is we're going to be putting out 2 guidance documents, and those are going to be out for public comment. And we're really inviting all of you to share your response to that guidance when it comes out. The first round of guidance is going to be including definitions of population-based prevention, some of what we were sharing today in the slides. And then also what we are thinking are some of the initial ideas about the focus for prevention activities, our shared strategies and priorities. We're going to put that out hopefully towards the end of March and want to get a lot of feedback on that, make sure that we're on the right track, see if there's anything we're missing. And once we confirm that, we'll put out some additional guidance later in the spring around the operational model. So how would we put the funding into action? Who would the implementation partners be? How would that be structured? We think it's important to figure out the focus and the strategies first and have good consensus on that, and then use that to determine what the operational model is. And so we're very excited to get feedback around all that. I should also clarify at the beginning, This BHSA funding doesn't start until July 2026. So we're in a planning process to ramp up towards that implementation and trying to use that time to work with everybody to help inform the approach. Next slide. And so, yeah, so I think now we want to just open it up for questions about the process or feedback you have for us, things that you think we might need to consider. And some of your questions we might be able to answer, and others we might need to take back for our planning process, but we just really value the time with all of you today.
Thank you so much, Julie. I am so happy to hear about the prevention strategy. You've mentioned this, social connection and the mental health being a prevention to a lot of the things that you said. But for this group to know, we know social isolation, depression, anxiety increases the risk for dementia. And so preventing and addressing this earlier on will help us with this growing population that we're anticipating in the next several years. So thank you so much. So anyone, questions, feedback for our group here? Catherine? Oh, you're muted.
Thank you. I just want to start by thanking all of the presenters. Really powerful, and I think it shows the strength of this commission where the lived experience can inform the professional work, and then we can learn from the professionals' work. So I just honestly grateful. I found it to be very emotional at the beginning. So I just want to acknowledge and thank you for taking that risk of sharing what was going on in your life. I don't know if Emily is still here or not, but just wanted to acknowledge that. My question is, I have been doing a lot of work around legal aid funding to help communities that are currently marginalized as a result of sort of changes, what's happening federally. And when you describe what, the impact of isolation and vulnerable communities, I guess I'm interested, is there a lens that talks about immigrants, particularly in the current climate, where people are afraid to make any kind of connection because of the risk that it imposes to their physical safety, their well-being, and every other aspect of their life. So I'm just interested in hearing, are we shifting to do that? Maybe that was already part of the calculus, but it's important, I think.
Yeah, absolutely. And I think it's definitely a both and. I think that historically, a lot of local behavioral health prevention work has also focused on, for example, immigrant communities, refugee communities, LGBTQ communities, and other communities that are impacted by racial discrimination, because there are these elevated exposures that contribute to behavioral health harms. And then I think we're just seeing that exacerbated in the current climate. So we are definitely thinking about and would welcome input on how do we ensure that the strategies we put in place in BHSA are responsive to the fact that that's heightened even more right now. And so we would really appreciate your input on that. And I'll also add the other lens, which came up on our call earlier, is also in recovery from disaster is another thing that is definitely affecting behavioral. So I think that's part of the landscape that we need to bring this prevention work into.
Dr. Moley.
Yeah, hi, Julie. Thank you for your comments. The concept of belonging, the concept of connecting with others to avoid loneliness, it seems to me is about as important as anything else we've talked about. I could encourage a very social neuroscience informed approach to this, because it's not so easy to think about belonging and the elements of belonging and how to enhance belonging in populations. Very likely, there'll have to be a solution that's different for each of several different kinds of populations. But I would really encourage your office to think about reaching out to the academic community to become really quite deeply knowledgeable about what we mean by belonging, and how we combat loneliness.
I just really appreciate those comments, and I may not respond to every comment just because I want to maximize the time to hear, but I just think that that point is so relevant, I think, for us understanding what it means to be effective in that. And one of the more detailed sort of approaches that I didn't speak to specifically is we know part of this work also needs to be building and sharing the emerging evidence of what is effective, especially when it comes to complex questions like fostering belonging in conditions that we're in right now. So just really want to mention that and also put it on people's radar that the idea of figuring out and sharing what works, both from community experience and from the research institutions, is definitely a priority for us.
Great. Jason, welcome.
You set yourself up really great for my question here, which is, there's so many things identified as potential risk and prevention strategies. What is the plan to prioritize? Because there is some limitation, right? Financial and structural limitations in implementation. How does one take all of the many and varied risks, right? Risk factors and opportunities, and prioritize them in this timeline?
Yeah, that is the biggest challenge. And I mean, one of the benefits is we also know that many of the outcomes midstream and downstream that we're trying to address have common risk and protective factors. So if we can address some of that prevention, it could affect a lot of different outcomes, but there are a lot of those risk and protective factors as well. So I think the effort of sort of elevating the focus areas is our first lens at trying to do that. And I think that's also feedback that we're going to want as a part of this initial guidance going out. We'll sort of articulate our first version of that, and we'd love to get input on this still seems too broad. There needs to be further focus, or of what is being referenced here, this is what we'd recommend to elevate to even narrow that more effectively. And then we're balancing that with the recognition that needs of different populations and communities vary. So I think that's the polarity we're trying to navigate, and we need help with that. So, but I think definitely in the response to our first round of guidance is how we'd like to try to define that further.
Anyone else in the group? We're at 11:14, and so we have plenty of time.
Barbara has her hand up, Wynn.
Oh, okay. I don't know why I missed that. Barbara, go for it.
Thanks. I mean, I love the public health approach to things. It makes so much sense to me. I love the idea of prevention. And I don't want to be sort of a negative person in this conversation, but when I think about families like Emily's and others that we work with, just the other piece of this is it's hard to prevent mental health needs when some of the drivers of it are how hard it is to get a diagnosis, and the fact that we don't have a robust service and support system for families. And if you're not really rich or you're not on Medicaid, affording any of it. So I know that's what Susan laid out with the MPA and all that work. And so just underscoring how important it is if we really want to be truly thinking about prevention in the behavioral health space, how much work we have to do in the just delivery of services and supports. So thanks.
Fully acknowledge that. And I think it's going to be so important to coordinate across our different roles in state government so that the delivery systems are thinking about improvements that can be made. And then we're also thinking about prevention at all these different life stages, prevention to support caregivers to reduce harm down the line, prevention, even if there's existing mental health conditions, prevention of adverse outcomes through opportunities for connection. So, and want to, again, strategize on that with all of you. What are the things that are prevention focused, but also alleviate some of the greatest pressures that we're seeing? And also being really clear, we're not influencing the delivery system directly through these resources, but we understand that those two things are connected. So appreciate that.
Anyone else?
So I'd just like to say we really appreciate your feedback. I've been taking some great notes here as well. And it really is going to be important as we develop the guidance. We really want to hear from you. this is going to be an opportunity for us to be able to refine our strategies and talk about prioritization. That is going to be the key, right? I mean, we've heard from many communities and we have a lot of different, ideas and strategies. And I think for us is what are you going to, you're going to help us prioritize, I think, based on your expertise and particularly with the older adults. And so we truly welcome your input and ongoing feedback. And we're going to continue to work with Susan and Department of Aging to make sure that we are going to be responsive to the needs of older adults as well. So I really thank you for your input and look forward to your ongoing engagement.
I just make one request, which is, this committee has a lot to say about this topic, I think. And if there's a way you could make sure that the staff that supports the committee gets a copy of this that could then be sent to everyone. So we just had the best opportunity to make sure we had the document and knew the timelines to respond. I think people would really welcome that. So just for your consideration, thank you.
Yeah, and thank you. I just want to acknowledge too, Ranjana had put in the chat, we also have an email address. If folks are still processing and have thoughts after the fact, we'd welcome that. And then some of these links that are noted here, we do have a page on our CDPH website where we post our upcoming engagements. People can also sign up for updates. And we will be keeping this Department of Aging team informed so that they can also spread the word to these networks regularly so that everybody's in the loop as this process moves forward. We really appreciate that.
Thanks so much. Really terrific presentations. I'm going to just ask a process question of we're ahead, which is always great because we'll probably be behind by the time we end. So should we take up the 12:25 item, which will probably take a half hour, and then that'll put us on schedule for the time for public comment, or other guidance from CDA staff would be appreciated. It feels a bit early for lunch.
Hi, Catherine.
Ooh.
Yes, you can go ahead and proceed with the next item, and then we can go to lunch at 12:25.
Okay, so I think this is the item on our bylaws changes, right? Which I think is okay, great. So we're going to pull up the slides. Thanks for being flexible about how we do things. So we're going to do a couple of things. One of the ways that I think this committee had impact, and we're grateful for the Alzheimer's associations who supported the efforts to update our bylaws and all of their work, because we provide advice, but we're not the people that are actively working on legislation. But our bylaws were changed, and those bylaws do several things that the statute did several things that result in changes in our bylaws. And so you have a copy of our bylaws, and those bylaws reflect the following. They changed the name of our committee to better reflect what we're doing and to sort of remove some stigmatizing language in that. One of the things that I have been passionate about, for those of you that have been on the committee, is that individuals with lived experience, which are referred to, I think, as consumers in the statute, but they had a 1-year term limit, while everybody else on the committee had 3 years. And I think lived experience is so important, and that we should value those as much as any other member. And I think it reflects how we think about the experiences of people when we say you get a different term limit than everyone else. So yay. It also meant that we are able to now have equal term limits for everyone that's serving on the committee. And we're grateful for that. One of the pieces in the bylaws was there was initially an effort to increase by very specific positions, the composition of the committee, and that was not successful for the most part. We did, as we heard earlier, get a representative from the California Commission on Aging, and we have 2 new members that will be members of the legislature who are non-voting members. We were introduced to one of the staff representing a member earlier today, for which we're grateful. That's from the Senate, and the Assembly will also have an appointment authority. And then there's just updated terminology, thinking about how we refer to individuals that have lived experience. This also provided the in the bylaws a documented ability to reimburse travel costs for a caregiver of a consumer member who is traveling with someone as what I would call an accommodation for their disability. So that's also nice to see. So the statute made changes. We need to make those changes in our bylaws. I think you all have a copy of the bylaws. They were attached in the meeting materials. So we want to just start by asking whether anyone has any comments or questions about the bylaws changes. And then after that, there's some suggestions of the kinds of positions that the secretary could add to our bylaws, to our composition. And we want to just get your advice about what are the priorities for additional positions, sort of what's missing from our composition and what are the kinds of positions we would want to recommend adding. So we're going to do that. But right now, let's just focus on the bylaws and see if there's questions, and then we'll vote on them. Anybody have questions? And thanks to the staff who drafted the changes. I think that actually started with Michelle Johnson, who has left CDA to take on a legislative position with a different disability organization. But we're grateful for her care in drafting those changes, and for others at CDA looking at them. I think they're in great shape and incorporate all the changes we would want to see. Does anyone else have any questions about them? Okay, do we, I think we need a vote on these, and I want to just, I want to make sure I'm clear. Sometimes in Bagley-Keene, you have to call on people and ask them to vote, or can we just do it by a voice vote? Anybody know, care? You are on mute, and thank you for informing us, but we can't hear you yet, Rajana.
Hi, Rosie, if you can please place the committee member names so Catherine can read off for a vote.
Okay, great. So this is one of those opportunities where we need to ask each of you to vote. I think that because the Senate position is non-voting, we will not call on that person, correct? Right? I think that's right. So, let's do it like first, is there a motion to approve the bylaws?
I'd make a motion to approve the bylaws.
Thank you, Barbara. And is there a second?
Second.
And who was this?
Second the motion.
Oh, great. Dolores, thank you so much. Appreciate that. Is there any other discussion or questions? And if not, I'm going to call your name, and your job is to say yay or nay in terms of approving the changes. So, Sally Bergman.
Yay.
Claire Day.
Yay.
Dr. Dolores Gallagher Thompson.
Yay.
Lyra Garcia.
Yay.
Ken Graffio, I think, is not with us today. Barbara McClendon.
Yay.
I think we might need our next slide. Dr. William Mobley.
Yay.
Carla Olivas.
Yay.
Dr. Quasi.
Kazi, yay.
Thank you.
Yeah.
Appreciate the correction.
No worries. Yes.
Celine, thank you for voting. And Celine Regalia.
Yay.
Todd Shetter.
Yay.
Julie Solier, are you a voting member?
I believe so.
Fabulous.
Let me double check. But I will give you an eye right now anyway.
Okay, and then we'll note otherwise, it would just be an
Yes.
abstention.
Exactly.
And I don't know, so Dr. Farias is not here. Jason is here, but I don't know that, I think they can't, I think they can't vote because they're filling in, right?
That's correct. Yeah.
Okay. So the motion is approved, which is great. We have a new set of bylaws. Thank you, everyone, for your efforts in getting the statute changed and for the care that was taken to give us a set of bylaws. That's wonderful. Now we're going to go on to, I think, an interesting discussion, and there should be a slide for that. So, Rose,
Catherine,
yeah, go ahead.
I'm sorry, we have public comment.
Oh, about I thought we just took
Oh,
public
yes,
comments
yes,
during
yes.
the public comment
Apologize.
period, right?
11:45.
Is that okay? Okay. So so our current composition, this is what this is talking about, is we have two individuals that are identified as consumers. I call people with lived experience. We have two of those. We have two family caregivers currently. We have service providers and consumer organizations. We have representation from research, medical and social. We have behavioral health representative, adult day services representatives, Alzheimer's disease representatives, legal representatives, and a designee from California Health and Human Services. We have 10 female, 5 male, 1 Latino Indigenous, 2 Asian, 9 from Northern California, and 6 from Southern California. So that's everything that's on the slide, just giving us a snapshot of what does our representation look like currently. And we have some, because the statute identifies other types of positions that can be added at the secretary's discretion. Let's look at that slide and sort of start prioritizing what some of our needs are. I think the next slide does that. So we have added the executive director of a position of the executive director of the California Commission on Aging or their designees. So grateful that has already been taken care of. As I mentioned, we have a Senate representative, and I'm sure the Assembly is working on their representative, which will be great. And then the secretary may appoint up to 4 additional members. And the initial version of this bill had identified some specific slots. Those included local health jurisdictions, first responders, primary care physicians. Our job is, as it always is to give the secretary some advice about the kinds of characteristics that should be identified for people that are applying. So it could be the type of position, it could be an effort to make sure our commission reflects the diversity of who lives in California and the aging population. So it's just up for us to provide some advice, and that'll get incorporated into the letter to the secretary that we send at the end of the meeting. So interested in people's opinions about important things that should be looked at when we're looking for new committee members. Go ahead, Barbara.
I'll start with a question. So are you asking for input into those 3 areas that were originally in the bill as to whether any of those should carry forward as a priority for the secretary, and other areas that
Both.
can we do both?
Yep.
Okay.
Completely open. It is
Okay.
our time to give
that.
Advice.
Great. I mean, it won't come as a surprise to anybody that I'm going to again raise up first responders. So I think that this is of dual importance. On the one hand, we know that wandering is an issue for families living with cognitive impairment, right? And so you've got all kinds of law enforcement that get involved when someone wanders. And then we have disasters, and that our folks are just at they're very vulnerable. And to date, I'm hopeful that the tragedy we experienced here is going to spring us forward into having more integrated conversations when it comes to emergency planning and preparedness, but we are definitely not there yet. So I really do think a representative from that first responder emergency services space would be very helpful in our conversations. And I do think, primary care physician, I was just in a meeting on something, and I have a primary care physician on my public policy committee, and he was just so incredibly helpful in this conversation because he can just speak very concretely to the experience that he has seen of people accessing healthcare, people being in the hospital. What is that like for those families? How could we do that better? And then the third is a brand new one that I'll throw in here. And this is just the homeless services housing space, because we know that the number of people who are homeless on the street, that's aging. And so among those 50 and over who are on the street, probably at least a quarter of them are living with some kind of a cognitive impairment. And we've been working for what feels like decades on building a dementia-capable healthcare services delivery system, and we have lots to go. We haven't even started talking about a dementia-capable homeless services system. So it would be, and I know that world is complicated, lots of players, lots of regulation. I mean, it's like higher math to me. And so I think having someone on our committee who has expertise in that area would be very helpful.
Thanks as always for your great ideas. Appreciate that. Dolores.
Yeah, so I'd like to second what Barbara has said about the first responders, but I think it would be good to carve out within that the police as a separate group, as a unique group within that, because I think they have so much contact with the people that we're trying to help, and so much of it goes wrong. I mean, I just hear so many examples, and in my practice, and it's very disturbing to all concerned, and there's no easy fix for it because it's piecemeal. We do education. I'm in Santa Clara County. There's some Santa Clara County education that does go on for police and fire that's unique to them, and tries to deal very hands-on with what they face, because from their perspective, they're facing challenging situations that they readily admit they don't know how to handle. So I think I would carve that out or somehow modify, specify the language a little more clearly on that. And the other thought that I had in listening to this was if we wanted to consider perhaps clergy persons, because I believe that for many older individuals, the spiritual aspects of aging are very important and are not well integrated with the mental health, the behavioral health, the medical care, and so forth. And I don't know, because I don't know if that's allowed for our committee to go in that direction, but I think we might find a richness in including a person like that.
So thanks for the good suggestions. And this is really our chance to brainstorm about the kinds of people that would add to the depth of experience. So I really appreciate all of what you said. Claire.
Yeah, and just sort of propelling off of Barbara and Dolores, I think the needs for of a first responder, an EMT versus a police, what they're experiencing is completely different. So I just want to echo that importance of really understanding the difference in that and how they can contribute. But I would also add, it's interesting you talked about clergy, because I was thinking parish nurses, for example, the people that are working in community at a place of worship would be lots of houses of worship have, in addition to the pastor or the priest, a team that is working in community, and how could we tap into that?
Dr. Mobley.
Yeah, I would echo Barbara's comments. I'll specifically address the PCPs. I really, from my perspective in San Diego, but more generally through Dementia Care Aware, it's very clear now that an increasing number of people are coming to their primary care provider just to understand what's going on with them as they age. And having a PCP on the committee to begin to inform us about and to learn from us about what we're seeing in California and how we might affect policy, I think would be very, very helpful. Not the least of which is, if you remember, Emily made the comment that she had consulted 2 neurologists and that they were not the least bit helpful, right? They were completely uninformed, emotionally unintelligent about the need for care for this poor woman. And I think having an increasing presence of physicians on the committee who take seriously the obligation to educate their colleagues about the real difficult emotional and social issues that are faced by people who are aging, especially those who are undergoing dementia, would be very, very important. So I would really recommend that. And then maybe I'll go back to Barbara. The last comment you made, it seems to me, was really important. How do we address the needs of the unhoused, dementing population, which is such a problem and so underserved? I'd love to know what kind of person that would look like, but I'd love to know your thoughts about that and how we might, as a committee, pay special attention to that very important group.
Yeah, it's a great question. And because I've only been dipping my toe into this space, I don't even know if I know the answer at this point, but I would love to put it forward to the secretary for conversation. And so that she can talk with those, at the state level who do have that expertise. So I don't know if that's like community corporation for supportive housing, or if it could just it looks different ways in different communities as well. But if we really get a chance to dig into that, I think we could talk about which slice of that we think would make the most sense for the kind of conversations we have here at this committee. Because I really hear we can't add like 15 people, but when everyone's kind of parsing out among first responders, I'm like, oh yeah, that's true. That's true. We're making a good case here. So, I feel like we could almost do the same in the housing and homeless services space. And I know that's not feasible. So,
Yeah, I was just going to add to the housing and homelessness space. Well, I've been doing some work on the master plan for the developmental disability system, and we had this really phenomenal presentation with people with all kinds of different expertise in housing and what it takes to develop housing. And I will find the slides from that presentation, which has the presenters, and send them on to the staff here. They may not be the right people for this group. This was sort of people that are doing work in a different space. But the conversation was rich. There were lots of things to think through, and it might give you some ideas of like the kinds of people. And I think having a presentation about housing and what needs to be developed and where are the gaps would really be an interesting discussion for this committee to have, because it is something that every community in California is struggling with. It's now been made worse by the wildfires in Los Angeles. So I just think there's lots of interesting things to say.
I wonder if we could ask Dr. Margot Kuschel from UCSF to come and present.
Yeah.
She's presented to other committees that I've been a part of,
idea.
But she's just like, she's got all the data. She could lay this out for us in such a clear way.
And I think then some people that are maybe building on her laying out sort of what's happening with the experience of trying to do that. That would be great. Okay, I'm not seeing other. Myra, did you have a suggestion? Yes, go ahead, please.
Yes, please. It took me a great long time to get my diagnosis of early stage Alzheimer's. I felt that it was happening. I knew it because it's in my family. And I went to so many doctors, and they would give me a simple test and said, you're fine, come back later. And so I think it's very, very important, that one piece. The other part is not about the fires, but what happens to people who perhaps don't have the abilities to really know what to do because of their Alzheimer's or whatever is the situation. And I saw where my aunt and my cousin, they both had Alzheimer's, and it was a terrible situation. They were kicked out of their home. So, these are just, little snippets of what it's like to have this disease.
Yeah. Thanks for that, and really, really valuable input about areas of focus and the kinds of people that should be part of the discussion, I think. Jason.
I think talking about first responders is it highlighted for me again the additional maybe carve out of emergency department physicians or staff. They are again the no wrong door entryway for many people living with some thinking changes and having medical events that are potentially preventable in some ideal settings. So forgive my ignorance that that's already a part of this composition, but something along those lines, it would really, I think, complement the primary care addition as well, because it's just another way in that people get identified as having some trouble or being at risk of having trouble, and all the policies and other things that go into that triage. Be helpful. And then one thing that came up, this is not a suggestion for the group, more of a thought, is that it seems as though representation of incarcerated individuals is just not a part of this conversation, and I don't know how or when that would come up, but it's certainly, I think, a rising issue with the aging population in general, or aging incarcerated individuals in California. So I don't know how that
We
would play
actually
into
all
this
like
conversation.
topics of things we can think about adding to the list of things to discuss. So separate from like who should be on the committee, for example, I think really helpful. And we can, when we're putting our letter to the secretary at the end, make sure that gets mentioned. Okay, Dolores.
Yeah, I was thinking about financial protection for seniors with Alzheimer's. So many are victims of scams. I mean, you read about it all the time in the newspaper, and I'm sure that only is the tip of the iceberg. Is there any way to have a representative on the committee that has something to do with protection of financial assets or I don't know the right terminology. Maybe our lawyer, Sally, would be able to know what I'm talking about, in terms of the financial vulnerability of seniors with dementia, and how is there a way that we could have someone on the committee representing an advocacy group or a group that is trying to reduce the frequency of these scams, which are statewide apparently, and perhaps hold them accountable so that they stop happening. I don't know.
Yeah, and I think you're also raising another sort of topic for discussion, I think, that can be important. And I think there's the Elder and Disability Justice Coordinating Council, I think is the name. And I know they have a focus on abuse generally and potentially financial abuse. So let's add that also to the list of, we always create this list every year about the things we want this committee to talk about. And we've actually done a remarkable job of getting through a number of them. So I think that's another excellent place, in addition to the idea of, who could represent. And Sally, I don't know if you had something to add to that, but feel free.
Yeah, I kind of going back to, I recall when and I did the presentation on mental capacity, and being so shocked with the statistics of the number of physicians who do not feel capable of assessing mental capacity. And I guess what I see that I find so disturbing is the number of calls I get from people who are very advanced and the only choice they have to help them move forward, both in terms of where they're going to live and how their finances will be handled, will be by way of a conservatorship. And for the most part, it's so avoidable. But again, I think you're right. It has to start with that primary care physician diagnosing them and getting them into the system so that they can get the resources that they need.
Yeah.
And
Thanks.
plan
Thanks
to
for that.
avoid this.
Yeah. Really, really great wisdom, Sally. Thank you. So I'm gonna, because we want to do public comment before we take our break, because that's what we promise our public. I want to just do two things. I want to say that my term is up after this meeting, and Todd's term is also up, which means there will be those positions to fill. And I want to say for me, this has been one of the most impactful experiences in my life, and I'm so grateful for the opportunity to have been part of this commission and the opportunity to help frame what we've been talking about. And the fact that we have such diversity of opinions and we come up with topics and we kind of dig deep into them and we make recommendations, I think can't be underestimated. And each of you who's taken a role in helping to present and sharing your knowledge and helping us craft recommendations that represent this breadth of experience, I'm just incredibly grateful. I know that aging is great, Department of Aging and their staff are grateful for all that we do, and the administration. So just thank you for the opportunity to do that. Wynn, who has been our vice chair, has agreed to become the chair of the commission, which is wonderful, make an incredibly smooth transition. So thank you for that. And Carlos has agreed to become our vice chair, which I'm also incredibly excited about. I think having that partnership between a professional and a caregiver or an individual with lived experience is just so important in terms of raising issues and looking at things from multiple perspectives. So grateful for that. Todd, I don't know if you want to say anything, and then we're going to go to public comment.
Sure. Thanks, Catherine. I will echo. I have learned a lot. I have been fortunate to kind of get windows into worlds that I didn't know existed. And so it's great to see that all this work is going on behind the scenes, and appreciate being included in it. And feel very fortunate to have met a lot of people, been there a few times in person, and being able to share some of the knowledge that we've learned along the way too. So good luck going forward. And I know that you all are for seniors and those with dementia. So I appreciate all the work everybody's doing.
Thanks so much, Todd, and thanks for your many contributions. Okay, with that, I'm going to turn it to Carol, who's going to do our public comment period.
Thank you very much. This is our public comment period. I will spotlight myself. There we go. If you would like to raise your hand and you're attending via Zoom, you have a raised hand icon. Please click that and we will unmute your line. If you are attending by phone, it is *9, which will indicate to us to unmute your phone. So any comments, please? Now is the time. Of course, if you have comments later and you wish to email them, please submit to our email box, engage, ENGAGE @aging.ca.gov. And we'd be happy to forward those on, respond, or do what we need to do. We'll give it a few more minutes. Maybe we all need a little cup of coffee, maybe some lunch. We'll have another public comment period towards the end of the meeting. Catherine, I think that you and the committee have given the attendees lots to think about, and or maybe you've answered every question and there are nothing left to ponder.
Okay.
But I turn it back. We could give it a couple more minutes. I will also say again, please, if after this you wish to write your comments, which I like to write things, please send on to engage at engage@aging.ca.gov. I'll turn it back to you, Catherine.
Thanks so much. I think what we're going to do now is take our lunch break, and I think we'll just return. We're really close to the time we were going to take our break anyway. At 12:50, we are going to hear from Susan, who's going to give us CDA update. She did a great job this morning. I'm sure there's more to tell us because there's always a lot happening there. So we will see all of you back at 12:50 and look forward to that. And thanks everyone for your comments in the chat. That was lovely of you. I appreciate that. All right, take care, everyone.
Just
Hi, Catherine. It's a 30-minute.
30 minute. I thought I'm sorry. You are
No
right.
worries.
You are right. I forgot we already did one part. Come back at 12:25. Do not come back. But Susan will start early at 12:25. Thank you. I appreciate you correcting that. That would have been quite a kerfuffle. All right. Thanks so much.
Thank you, Catherine.
Thank you. Bye, everyone.
Thank you.
Soon.
I'm ready to go, so we will resume the meeting then. Thank
Okay.
you.
Sounds fabulous. So
And I do just want to thank everyone for such a rich conversation this morning. It looks like Emily is not part of the meeting any longer, but I just really appreciated her heartfelt experience, and also to hear both of you sharing experiences from this morning. It just really doesn't get more real than that. So my thanks, please, Barbara, extend my thanks to Emily for joining us today, and also to Julie, presenting from the Department of Public Health. And then also, Catherine, we talked about the leadership baton passing. You've been an outstanding chair of this group and have really moved it in such a productive and positive direction, with Wynn right by your side. So what great continuity, Wynn. Thank you so much for agreeing to chair. And Carlos, we welcome you now as co-chair, and you have so much to bring and contribute as you've been doing since you joined as a member. So this advisory committee is in excellent hands, and I really endorse the suggestions you made about who should join this advisory body to bring even additional perspectives. So thank you. My update today is pretty quick. We actually already touched on a few of the points, so there are a couple of slides to share. I wanted to just bring you current on what's happening with the Department of Aging. Earlier in the meeting, we did share with you, Callie, that one looks like it may not be a full link. There we go. Earlier, we did share with you the Master Plan for Aging annual report that was issued last year, and you'll see, many of the achievements point right straight back to you, as Secretary Johnson said, things that we accomplished together last year. And then the 81 new initiatives that we are embarking upon. You've already touched on a number of them already in today's meeting, but certainly older adult behavioral health will be a big focus area. Further CalAIM implementation. You've talked about community supports and enhanced care management. We will be redoubling our efforts around disaster preparedness and emergency response, and you'll see more work around the missing or forgotten middle, or a term we are introducing, the overlooked middle, which reflects people who are caught between Medi-Cal and private pay. So more to come on all of those initiatives. And everything you've talked about in terms of a focus for this group going forward aligns perfectly with the Master Plan for Aging. I did want to, there we go. Thank you, Ranjana. This fall, when we released the updated guide for older adults, individuals with disabilities, and people with access and functional needs, we were very proud to work with the Governor's Office of Emergency Services and the California Department of Rehabilitation to produce that together. And we all independently and collaboratively got a lot of outreach in the fall and September, which was Disaster Preparedness Month. We did some media interviews and, thank goodness for that, but it in no way prepared us as, we couldn't have prepared for what was to come in January with the Southern California wildfires. So that's a really strong foundation for us to build from. We are thrilled. The Department of Aging has a new deputy director in Anna Acton, who previously worked with the Department of Rehabilitation, has joined our team recently. The Department of Rehabilitation just appointed this week a new director, Kim Rutledge, who we've worked with so well for many years. She replaces former director Joe Xavier. Our Department of Developmental Services also has a new director, and so we're really excited about the new energy. These are people with long-standing commitment to people with access and functional needs, the disability community, and just exceptional new leaders that we get to work with. So I'm very encouraged about what's ahead in terms of collaboration and breaking down silos. And what we've heard from Los Angeles, as the secretary said, she spent well over a week in the field. Our governor and our first partner have been in the field, off and on, nearly every day for the last month. I was able to spend some time at one of the shelters and both of the disaster assistance centers, one in Pasadena and one in at UCLA. Talking to our partners, Office of Emergency Services, FEMA, American Red Cross. I cannot say enough good things about Dr. Laura Trejo, who leads our Area Agency on Aging for Los Angeles County, and Jaime, who leads our Los Angeles City AAA Area Agency on Aging. We've been in daily contact with them, our partners in the Caregiver Resource Centers. We continue to learn each time this happens, and it's too soon to do a look back because they're still very much in the thick of it right now, but we will absolutely be sharing out our lessons learned, and all of that is being well communicated up to me, up to our secretary, up to our governor and our Office of Emergency Services. So more to come on that. And our next slide, let's see a couple other ups. Yes, so our department, for those who are interested, we just updated our own internal strategic plan. It took effect in January. It is a 4-year strategic plan. We're really excited to align. We will be updating our state plan on aging this year, so it has a 4-year horizon. Our strategic plan has the same 4-year horizon. Our master plan for aging has 5 more years and moves in 2-year increments. So we're seeing a lot of alignment. I would say we're sort of catching our breath after COVID and the ARPA funds, and it's a period where we're able to really pull together large pieces of work centered and anchored on the master plan for aging. So our focus at the Department of Aging is on people and populations is our number one focus. So really our goal is to serve more people and to serve more underrepresented, underserved, and under-resourced people and communities, and to put a bright spotlight on populations that have been overlooked, whether that's the LGBTQIA plus population that we just concluded a report on, tribal populations, as I said, the missing or overlooked middle who do not qualify for Medi-Cal. So people and populations are our first priority. Our second priority is performance. We really are focusing internally on how we future-proof our department and our aging network for what's ahead with the demographics. We can no longer do workarounds and one-off solutions when we're talking about 10.8 million people in our state. We really need to be high performers and have a systems approach to our work. And then our third, you come in for all of these, but our third priority after people and populations performance is partnership. And so we realize as a small department, we need to leverage our sister departments, other agencies in state government, local partners, CBOs, county partners, and of course, our federal partners. So that's our strategic plan. You're welcome to look at it. I don't know if this group learned about our Cal Cares grant for family caregivers. We were awarded this by the Federal Administration for Community Living at the end of the year. We're thrilled and already starting work on that. Sarah Steenhausen and her team are leading that work. It was a competitive award, and we're just thrilled that we received this new round of funding to really bring together our work at the area agencies on aging and the caregiver resource centers, and our caregiver equity roadmap that will be released this spring. So super, super excited about that going forward. And then this is a major milestone and a sad fact to report that our funding has concluded. Our CARES Act funding, our home and community-based services funding, as of September 30th. We still have some extensions in place, but by and large, most of the funding has concluded. All of our local partners have closed out their grants and awards, and they did such a phenomenal job of spending the dollars, reaching new populations. This group had followed the Cal Grows effort, and while we're sad to see that come to an end, we have built that into the Cal Cares grant, and our goal is to curate the trainings that were made available through Cal Grows and eventually the IHSS career pathways, to work with UC Davis Caregiver Institute to validate those trainings and to make available all those that we can public through our public website. Many of them are available today, multiple languages, and to have that collection and inventory available to anyone in California who seeks that free training. So more to come also on that. And just my huge thanks to our local and community partners that, we provided the funding, but they did all of the work and all of the outreach and produced the results. So my thanks to all of our community partners, many who serve on this group. Cal Compass was one of those examples that Celine has been leading. I know the Alzheimer's organizations were part of the Cal Grows effort, and others. So that concludes my update. If you have any questions of me, happy to take them, or we can move to the next one.
Anyone have questions about all the phenomenal work at California Department of Aging? Very excited about your new grant, by the way, and congratulations. Maybe is it worth just saying a little more of what you're going to be doing under that? I like the roadmap idea. I thought the caregiver roadmap was going to be phenomenal, and really helpful. So
yes, I will put the digest of the new grant in the chat, and everyone will have that too. And Sarah, if you wanted to, I see Sarah Steenhausen's with us too. Sarah,
Sure.
if you want to give a high level on the Cal Cares grant.
Absolutely. And we'll put a little summary of it as well in the chat, but it's a kind of 3 goal areas, and all of which align with the national strategy to support family caregivers. The first will be focused on enhancing outreach to caregivers, or caregiver awareness about recognizing the needs that they have, and developing targeted messaging that resonates for the different populations in California, underserved populations, communities of color. The second involves working to better understand how caregivers access services at the local level. So this aligns with the work we're doing to build out a no wrong door system, but we really want to understand the pathways to information and how caregivers navigate or don't get access to services. We all know that there's a tremendous challenge between the medical and the social services system. And for an example, if people aren't informed of the available resources by the doctors, then they don't know where to go for help. So we're really going to be trying to meet with caregivers in the community to better understand their pathways to services and supports. And then the third component, as Susan mentioned, we're really proud to be working with the UC Davis Family Caregiving Institute on the whole grant. And they're going to be working and developing a process to review all of the trainings from our CalGrow's workforce initiative so that they can be better curated, and that we can identify, are there any trainings that are missing that might be needed, and how can people best access this? These trainings are right now, several of them are available on our CalGrow's website, on the CDA website, but we're going to be building that out, as we said, together with our partners at UC Davis, and then eventually transitioning those trainings to our upcoming launch of the learning management system here at the Department of Aging. So that's a longer term goal.
That's amazing. What great items to have. So thank you.
Catherine, there was one other thing I wanted to mention. We've taken quite a few calls in recent weeks about some of the notifications coming out of the White House and federal transition. And I just want to say to this group, for the time being, it is heads down, business as usual. We are closely monitoring everything as a Health and Human Services agency across the Newsom administration, working closely, of course, with our State Attorney General's office. And if there's ever anything that impacts you, we will be sure to alert you. And for the time being, we're just closely monitoring and assessing things as you are. But I know, looking at the group around different, the scientific community or Medicaid providers like Celine, and we continue to uphold California's values. The Master Plan for Aging is centered in equity and inclusion, and we're being vigilant. Our governor was in Washington, D.C. just yesterday, so at the time, programs, services, and funding continues uninterrupted.
Thanks for that reminder, Susan, and good news. I always say I'm so proud to be a Californian and live in a place that shares those values. So glad to know it's business as usual. But Dolores has a comment.
Yes, thank you, Susan, for all, and Sarah, for all of this valuable information. I'm just wondering if there's any chance that CalGrow's will be refunded, that CalGrow's itself might be refunded, perhaps after UC Davis finishes their evaluation, or is there any hope of that on the horizon, or is that pretty much done?
For the time being, it is done. The funding has concluded. I'm not aware of any proposals to continue that funding. It wasn't included in the governor's January budget, and I haven't seen any advocacy proposals come forward at this time.
Thank you. Is there anything is there any interest in the rest of this group in perhaps developing an advocacy brief on that topic of CalGrow's? I don't know who to ask that of. How do we, if there were interest, I'm obviously interested. I don't know if others are or not, but I've been working on a CalGrow's project with the Southern Caregiver Resource Center in San Diego, and it was just phenomenal. They did amazing outreach to Latino populations because the material was in Spanish as well as English, and I imagine that other organizations that got the grants probably also develop multilingual information. And So it seemed like a wonderful program. We have many ideas for continuing it because we were limited in the content and so forth. And we just wondered if there was any future on that or another direction we could go with that idea, because it seemed to resonate really well, at least in Southern California.
It sounds to me like that is a discussion for advocates and people that care about the program to have, right? That I think we know where the administration is on it, and it's just work to do. And it's really good to hear about the importance and the positive impact it's had.
Okay, thank you. I'll work on that.
Connect with Barbara. She's always a good resource of what are the opportunities.
All right. Thank you.
Other questions for Susan? Or Sarah, for that matter, who gave such a lovely overview of the grant. Okay, I think then big thank you for all you're doing and for the really helpful update. I think we will then turn to our next. I just don't know if our presenters are here, so I'm going to need somebody to help. Tina is here as always. That is great. I am actually going to turn this presentation over to Wynn. One of the things, I'm the chair of the California Access to Justice Commission, and we were able to get funding for some legal aid programs to represent immigrants and other vulnerable communities during the special session. And so I need to, in a few minutes, run off to a meeting about that, but I'm hoping to be back in not too long. But I don't want to be disruptive with all the amazing things Tina's going to be talking about. So Wynn, if you don't mind, I'll just turn it over to you.
Of course. Thank you, Catherine. I'll see you in a little bit. So yeah, now we have an update from the CDPH by Tina Fong. Always lovely to hear the updates from them. Take it away.
Great. Thank you, Dr. Canio, and thank you, Catherine. Good afternoon, everyone. My name is Tina Fong. I'm the manager of the Alzheimer's disease program within the California Department of Public Health. We don't have a lot of updates since our last meeting in the fall. Next slide, please. So our program focuses on 3 different categories with different goals. We have prevention, clinical and caregiving, as well as research and evaluation. So I will start with updates in our prevention pillar. As you can see, the California Healthy Brain Initiative. ADP currently funds 13 local health jurisdictions through the California Healthy Brain Initiative to implement public health strategies that promote brain health, address dementia, and support people living with dementia, and as well as their caregivers. And this state project is modeled after the CDC Healthy Brain Initiative roadmap. So the project term will end this fiscal year. Right now, the 13 counties continue working on goals that were set forth by the national initiative. And ADP is in the works of an evaluation report of the pilot cohort. So that cohort started their project from 2020 to 2022, and we are anticipating dissemination of that report within the next few months. Next slide, please. Right now, ADP is in, excuse me. We are in year 1 of our block grant from the CDC. ADP intends to use this grant to expand the California Healthy Brain Initiative to work the HBI work to include tribal as well as rural communities that are currently not funded through HBI work. For year 1, we are focusing on conducting a community needs assessment. This work will be continuing until 2029, and big picture ultimate goal would be to expand HBI work to historically underrepresented and underreached communities and rural regions of the state. Next slide, please. All right, now on to clinical and caregiving. Next slide. ADP is currently partnering with the University of California, San Francisco and Fresno and the University of California, Irvine to create a caregiver training and certification curriculum. This project aims to expand access to evidence-based dementia-related education and training for caregivers with a specific focus on unpaid family caregivers. ADP anticipates the final videos and module guides to be completed and available by spring of 2025. And next slide. For research and evaluation, we just started hosting a series of research topics. We call it our research symposium, and it's to bring ADP partners together to listen, learn, and have open discussions on ADRD research and to provide more opportunities for alignment and collaboration. The symposium sessions are hosted quarterly. Our third session will be actually held tomorrow, February 7th, via Zoom. The presenters include Dr. Yvonne Wan from UC Davis and Dr. Timothy Chang from UCLA. They will be presenting on the use of machine learning in electronic health records to identify the risks of Alzheimer's disease. And we are in the process of scheduling the next sessions. The next topic we will focus on is health disparities, so please stay tuned for an actual date on that. Next slide, please. And that concludes the updates from CDPH. I know Dr. Gravano is here, so if he wants to give additional updates on the caregiver training, he can. Otherwise, we'll take questions. Thank you.
Sure, I can provide a brief update. We are luckily now partnered with some great media-like companies to make sure that the video modules are palatable and accessible to all the people that are going to be able to use them on the online platforms. This has a couple different steps, and two of the modules, as part of our expert review, we needed to revamp a bit. And so we're still in this iterative process, but primarily the content has been outlined, and now it's just the production, right? Production of these videos, which have, again, all our foundational stuff with CDPH and conversations in those monthly meetings. So we've made good progress. The timeline, as you all know, has been delayed to our chagrin. We're hoping to get these out a bit sooner, but we're still continuing on with this in mind as foundational trainings for pointing people in the right directions for these difficult caregiving topics.
Thank you, Dr. Cavano.
Thank you, Dr. Gravano and Tina. Do we have any comments for our CDPH colleagues? All right. Well, oh, somebody's saying something? No? Okay. Well, thank you so much. We've made a lot of progress since I started this in aligning with CDC initiatives. So thank you both for giving us that update. And now we're really early. We're going to move on to our legislative update. And Barbara and Eric, you ready?
Yeah.
Great.
Right. I mean, I think you can take, I don't think either of us has slides. So if you want to just put the gallery up so we can see each other. If there's questions, I think that would be fine. So I'll start us off. There have been very few bills filed yet that relate to our issue area. Maybe 10 of them, and a couple of them might be what we call spot bills, where language gets filed, but the intent is actually to do something totally different with it, and maybe entirely unrelated from the language that was originally filed. So I say that just because I think 3 of them look very, very similar to one another. And then the other side, the budget, the governor released his January budget, and then the wildfires happened. So I think that nobody quite knows how that's all going to play out. Obviously, huge X factor as to how much federal relief aid will come to offset some of what the state is spending up front. So I think most of the people I talk with are just like that was a great exercise we went through when the January budget was presented, but I don't think anybody thinks those details are necessarily going to carry forward. There were, in that January budget, no cuts proposed for programs that we care about, which is fantastic. We certainly hope that that continues to be the case as this gets worked out through the legislative process. And then my organization, Alzheimer's Los Angeles, we are in conversation with a couple of offices, and when we meet again, I think I'll have something specific to share about policy that we are looking to influence and change. Again, just the wildfires just really set us all off track. But the bill filing deadline is not until later in the month of February, I think maybe around the 20th. And typically what we see is a trickle of bills up till then, and then like the 48 hours before the filing deadline, it's a flood of pieces of legislation. So I think there will be plenty out there for us to be tracking, and for those of us who do advocacy work to be doing that advocacy. But right now, just with the timing of this meeting, I actually don't have a lot of detail to share.
Thanks, Barbara. Eric?
Great. Yeah, I will hop in. So as Barbara noted, it's kind of the ill timing to have too much deep discussion around what's happening in the legislature. Everything is kind of in the introductory mode. We're all shopping for authors, for bills, and we have a lot of interest. I will just talk a little bit about some of the key points and key initiatives that we're going to be pursuing this year. Just very broadly speaking, on the topic of the new therapies, so Kinsula and Leqembi. As you know, those are FDA-approved disease-modifying therapies offered through VA, Medicare, Medi-Cal. We are looking at other ways to make sure people have access to that, specifically around public employee health plans, so CalPERS in California. So we are talking to them through some legislative champions on how to ensure that CalPERS extends coverage for these therapies. So that's one item we're working on. We're also looking at the Medi-Cal cognitive assessments in an era where we may or may not have dementia care aware anymore. So as you may know, that those cognitive assessments, the billing code was tied to the dementia care aware training. We need to fix that should the training not become available. So that's kind of a technical fix that we're working on. The other area is home care aides. These are the ones specifically registered with the Department of Social Services. We're trying to make sure that they have kind of a baseline familiarity with Alzheimer's and dementia in general. There currently does not seem to be a whole lot of training requirements for that specific group. But if you progress into other areas, like even RCFE caregivers, there's quite a robust training. So trying to bring some parity and some kind of entry-level training requirements for that. And then finally, I think this is kind of breaking news. We just kind of happened over the last couple of days. We are going to be championing a budget increase for the Alzheimer's disease centers. So as you know, those 10 disease centers have been woefully underfunded for many years. There have not been many adjustments. I think since maybe 1980s, there might have been one in between now and then. So we are going to be asking through our legislative champions for a $5 million appropriation for that. So that's about $2.2 million kind of new funding to bring them up to $500,000 per site, which we think is still not enough, but at least it gets them kind of in a better financial position. So we do have commitments from some authors for that. So that's kind of later during the budget process, but a little bit of good news that there is some interest in funding them at adequate levels. So, and I think that is all. I'd be happy to, if there's any questions you have on any Alzheimer's related, aging related legislation, please drop me a line. Happy to answer any questions anyone has.
Thank you both for those updates. I think now it's time for public comments. Carol?
Sure, we can go into public comment. Let's put up that slide, Rosie. There we go. Thank you. We are ahead of schedule just a little bit. But this is our second public comment period in the agenda. And we do have one hand up. Again, if you have a comment, you can use your raised hand icon in your Zoom toolbar features. Also *9 if you were calling in. And we have Freddie Segal Gadan. I have unmuted your line. Want to remind comments are limited to 2 minutes. So please go ahead, Freddie.
Thank you for the opportunity to address everybody. And I want to follow up on both Tina Fung's presentation and Eric Dowdy's. So I, as you may recall, am the director of one of the state Alzheimer's centers located at Rancho Los Amigos. I presented last May to this committee, and I just wanted to provide a follow-up as Eric presented. The funding for the state centers remains to be a difficult situation, and I particularly wanted to bring to the committee's attention that it has become critical at my center. At this point, if we are not successful in augmented funding for the centers, as of June 30th, my center at Rancho Los Amigos in Los Angeles may possibly close. It's just not financially, fiscally sustainable. So I wanted to beseech the committee for their support, both for the legislation that Eric has presented about and a recommendation to the governor that he support that augmentation and to understand just how dire the situation is. I don't think other centers are quite at the verge of closing as mine is, but certainly for several of them, they're close to it. So I just wanted to follow up and thank you all for your continued support for the CADCs.
Thank you, Freddie. That was your comment as noted. Thank you so much. This is the public comment period. If you would like to make a comment, please use your raised hand icon or *9, which will also indicate. Of course, you can send your written comments at any time to our email box, engage, E as in elephant, N as in Nancy, G as in go, AGE @aging.ca.gov. Anytime you may submit those comments. We will certainly take them at any time. And if we have any more, otherwise, when
okay.
We don't seem to have any more comments. Back to you.
That's okay. Thank you. And I think now we should open it up for questions or comments related to the legislative update that was just given. for our group. Any quiet group today.
Yeah.
All right. we're gonna move on. And
Claire
you can
has
put
her
up
hand
that.
up,
Oh, who
or
was
she
it?
did. I don't
Yeah.
know.
No. That's
Okay.
my bad.
No problem. We can put up the slides. I think it's now our time to make our final recommendations for our secretary. I've written a few things as people were talking earlier. So especially with our regards to our committee, we are proposing to make sure we include the first responders, a primary care physician, clergy. Anyone else would like to add anything to our recommendations for the secretary?
Could we include my comment at the top of the meeting just about how we hope the secretary is a champion for ensuring that those fire relief funds, that an appropriate portion of them goes to help the older adults that have been impacted?
Yes, Ranjana, are you writing these down?
And I don't remember what we said about the unhoused, how we were going to address that as a committee to get some expertise to approach that subject.
Yeah, are we going to include in here, or maybe that doesn't have to go in the letter, but I think we noted that as a future topic for another meeting where we could have that expertise come and present to us. I think, do I have that right?
I think that's correct. That's what I have on here. There were a few topics that were included earlier that we might, or that we will pursue in the future. So it looks like reading the comments here. Oh, sorry, Claire. Reiterate the importance of funding for the Alzheimer's research centers and how we as a committee can support that. Thank you for adding that.
One thing I forgot to mention, apologies, this is Susan DeMorris again. Earlier when you were talking about housing and homelessness, and perhaps bringing Dr. Margot Kuchel, Secretary Johnson co-chairs the California Interagency Council on Homelessness with the agency secretary from the Business Consumer Services and Housing Agency, and Dr. Kuchel is a member of that committee. So that might be a nice connection to make in your recommendations.
Oh, thank you so much for that addition. Comment about second Claire's recommendations. Yes. And just to highlight what was discussed about the first responders, making sure that EMT and police kind of differentiating the two. Anyone else?
I think we also talked about financial vulnerability and perhaps having that as a topic for the future.
Correct, yeah.
Present to the group, yeah.
Yeah, I was going to go to the topics for the future after the recommendations, but thank you for including that. That's it, really? Okay. Well, it looks like we've already shared the topics for the future, Ranjana, if you, hopefully you've noted those down. So 1:09, do we really get to end this early? All right. So just our meetings for the rest of the year, May 1st, August 7th, and November 6th. And Catherine and I were actually wondering if there would be a one day out of these where we would all meet in person like before. We really found that very valuable to meet in person. Any strong feelings about which day, or well, for one, anyone would like to meet in person, and then two, which day out of those three might be a good day for people to meet? Obviously, there's the Zoom version that's still an option.
So to be selfish about it, the November date would be the easiest for me to be in person. May, the session is intense, and and there's already like 2 advocacy days that are set for that first week of May. So I think that's going to be crazy time. And then August, I think a lot of people are taking vacations, so I wouldn't pick that one as an in-person meeting.
Thank you, Barbara. Carlos is always there, so all days, right, Carlos? I think there's something on the chat. Selena agrees as well. So November 6th. Right, okay. So we have to vote. No, just Franchana or Carol.
Will there still be the Zoom option?
Yes.
Yes.
Oh, okay.
Yes. Yeah. I don't think this is a voting.
No,
but
just
I
a
could be wrong.
suggestion.
Okay.
Okay. All right. Well, I think I also agree with what Barbara said. I think November 6th might be a good time to meet, as long as there's no rain. But otherwise, or not rain, but storm. I think that's really it for the meeting, unless I'm forgetting anything. But I was hoping that Catherine will be back. Are you back yet? No?
Doesn't appear that Catherine is back yet.
Okay. Well, I just really want to thank her for everything she's done. She has been an invaluable partner for me, and I hope that I have learned enough from her to continue advancing our efforts. So Catherine, her leadership, dedication, and commitment to advancing the rights of older adults and adults with disabilities have really significantly impacted this committee and the Master Plan for Aging in general. Her guidance has facilitated meaningful discussions and driven impactful initiatives. So thanks to Catherine. It is recorded. Hopefully she'll hear it. And we'll miss her. I'm sure hopefully she'll join us in the public comments in the future. All right. I guess we will end early at 1:12.
Thank you.
Everybody.
Thank you.
Thank you, Lynn. Thank you, everybody.
Bye.
Bye-bye.
Thank you. Bye.
Bye-bye.
Bye.